as every month we have eminent speakers for the subject of hip and knee. And on behalf of my colleague, Dr. Krishna Kiran, who is the education chair, along with me, I am Dr. Dipak from Ahmedabad. Our president, Dr. Prem Khincha from Bangalore, Secretary Leo Joseph, Joint Secretary Dr. Dhanasekar Raja, our senior patron Dr. Pachore sir, he's also there on the line. We all welcome you for this teaching session. This month we are fortunate to have, like every month, two eminent speakers. The first is Dr. Ashok Kumar, who is a very well-known arthroplasty surgeon from Chennai. He is very well-known because not only his subject of uni, but he's working with a big team in Chennai where they are masters for the hip also. So he's a very versatile guy who is going to talk on the some finer aspects of the uni replacement. And after that, we have another eminent surgeon from HN Reliance Hospital, Mumbai, Dr. Vaibhav Bagaria. He's a techno man, been conducting a big conference on technological aspects every year, and he's going to speak on the acetabular defect later on. So before I hand over to Dr. Ashok Kumar, I would just like to request Dr. Khincha to say a few words, and then over to Ashok. On behalf of all our committee members, my colleague and executive board, the trustees, we thank both the speakers for sparing time and coming for this teaching program. Dr. Khincha, please.
Thanks, Dipak. There's nothing much to talk except to say that you're doing a fantastic job, and these guys have spent their precious time. I wish both of them all the best, and hope we have more and more participants every session we do for the hard work put in. And I hope we have some take-home messages. And as I said, punctuality is something which Ishks has kept on, and punctuality is not starting only on time but finishing on time. So I wish both the speakers stick to their time. We have more discussion. And hopefully everybody who's here listening contribute to the IJR and get as many members to the Ishks as possible so that we can hit 2,000. So thank you, Dipak. Thank you, everybody, for joining. And over to Ashok for his first talk.
Yeah, I'm sharing my screen, sir. Can you see my screen, sir? Khincha, sir? Yeah.
So you can see the screen. As Vaibhav said, I can see your bank account also.
Oh, excellent, sir. So you can see Dr. Suri's bank account also. So thanks, Ishk and entire team, all my seniors giving this opportunity, and my colleague Vaibhav Pearson. So today I'm going to talk about the basic principles of unicompartment knee orthoplasty.
Can you make it full screen?
Yeah, it's full screen. Yeah.
No, I don't think we can see the full screen. We can see all your apps on the computer.
Oh, I'm just making the full screen.
Yeah, we can see only the apps on the computer. Your thing is on the right-hand corner.
Full screen?
No. I'm not sure if others are able to full screen.
Vaibhav, can you just think?
No, I can't see your full screen.
No, we can't see the full screen.
You can't see my full screen? You can't see my screen? No?
No, we can see you now in the full screen.
Oh.
Dev, can you help?
Yeah, it's going. No, Vaibhav?
No.
Yes, sir.
Can you help for a full screen, young man?
Ashok.
Yeah.
Your presentation is open here?
Open.
Open. Okay, you go to the share screen button.
Yeah. Now
Okay.
you can see nothing. Yeah.
No. You put the share screen button. You have not still shared the screen. Go green button down. And then keynote you go. Your is Mac here? Mac?
Mac.
So share green button and then
Okay.
go to
However, I
the,
got it now.
yeah. Now you go to the presentation. The top,
Correct.
no, it's gone again.
No, I'm just doing it now. Yeah.
Yeah. So you just open that and then it will come.
I'm really sorry, guys.
No, I have to come and learn this in person sometime. I have never done this before.
It is not PPT.
No, you share it. I'll tell you how to do it.
Yeah. So I need always Vaibhav to be around. Yeah.
No,
Yes.
no. Yeah. So where is your presentation?
This is the presentation.
Which one? Where is it?
I opened it now.
No, it's not opened yet. So you go to the keynote down there.
No, I don't know. It's in PPT.
Okay. So what's the name of the PPT?
Ishks 220.
Yeah. So do command space. Put command space. Command and space.
Yes.
Together. Command and space together.
Can you see now? Can you see?
No.
Can you see in your screen?
I can see mine.
You can see your. Okay.
Yes. I can see nicely clear. It's sharing also.
Okay. Try changing, going ahead to the second slide.
Lost the voice.
Yeah. It's getting there.
Yes.
Yeah. Just click it again. Is it open on your screen
It's
now?
open. I'm clearly seeing. Yeah.
Okay. So go to the, there will be a play button on the top of the keynote. Go to that button.
Yeah. 1 second.
At the top.
So this is the finder. I can see this. Yes. I'm on.
Yeah. Go to the top part where your presentation is. There is an arrow, play button.
No, Vaibhav, I think you start. I'm just trying to do this. Yes.
Okay. Fine. So
mine is screen sharing. Yeah. This thing, everything is, I can see.
no, it's not coming to us. So you
Doc-
just, I'll start.
The Vama guys can help you if you can call them up and then see if you can do that. Okay.
No, Vaibhav can do that. Yes.
Can you
Yes,
see my
Vaibhav?
screen now? Yeah.
Vaibhav, I'm doing it now.
Oh, okay. You want me to stop sharing?
Yeah. Is it okay now? Can you see?
No, this is, I think Vaibhav needs to stop sharing.
Yeah, I did. I stopped sharing.
Can you see Vaibhav now?
No.
So we can see your laptop.
Desktop. Your desktop we can
Desktop.
see.
Yes.
So can you guide me, Vaibhav? What desktop?
Yeah. So you go to this place where your
Okay,
presentation is. Double
Desktop, you
click
can see my desktop. Okay, now?
Yeah,
No?
not yet. So is your keynote open on your
Yes,
presentation?
everything is open for me. Yeah.
So just look carefully. There will be a play button on the keynote, not on the Zoom, but on the keynote on the top line. Can you see a play button there?
There's no play button.
Okay.
The share, clear?
Yeah, your sharing has started. Now go to your presentation. Yeah.
Open the presentation.
Yeah.
Yes.
Okay. Go to slideshow.
Yes.
Play slideshow.
Next slide. You can't see my screen now? Share screen. Okay, Vaibhav.
Every time when you share screen, we see the desktop screen.
Icons. Yeah.
Yeah.
Zoom wants to know, everyone wants to know your bank account. Huh?
No, sorry guys.
Trying to
Can you
focus
see now?
on bank
Vaibhav,
account.
slideshow.
No, he can't see.
Right.
So the computer is telling that people are more interested in bank account than UK is. So
Okay, let's do one thing. Poonam or Dev, can you just help Dr. Ashok Kumar? Meanwhile, we request Vaibhav to start his presentation.
Correct.
Khincha sir, sorry sir.
Is it visible? Is my presentation visible now?
No, I think he needs to stop sharing.
Ashok, you can stop sharing.
Ashok has to stop sharing.
Yeah, stop sharing, sir. Stop.
Yeah, we can see your first slide, Vaibhav.
Oh.
Yeah, okay. So good to go, sir. Okay.
Yeah, good to go. Vaibhav needs time. That's it.
Yeah. So thank you, Professor Khincha. Thank you, Professor Dave, for giving this opportunity. It's always pleasure to be with both seniors and junior. It's as much teaching as much as learning in these programs. And as Sir said in the beginning, we want it to be interactive. So I'll not be putting too much theory here. We'll be discussing a few cases. And please feel free to ask questions and make this as interactive as possible. So coming to my topic, acetabular bone defects in total hip replacement. We know that they pose a significant challenges in THR, and they can occur both in primary and revision settings. So it's not necessarily a revision scenario you will find acetabular bone loss, but also in many primary situations. And indeed, when you look at all of these X-rays, you will find that there are a variety of it, both revision, primary, post-traumatic, non-traumatic, inflammatory arthritis. And in day-to-day practice, we'll find that these are a challenge to us. Now, what do we do when we look at these cases? So always remember the goal is 3-point things. One is to get a stable fixation. Number two is to restore the biomechanics of the hip. And number three is to get long-term survivorship. These are the three critical goals that we have when we are doing a hip replacement or when we are doing any complex surgery around the hip. If we get our fixation right, if we restore our biomechanics, and if we ensure our long-term survivorship, that's it. That's what we want to aim. And this is true for all these situations that I mentioned. Now, when you look at acetabular bone defect, it is important to do X-rays. You do AP pelvis, and you can do Judet views. Nowadays, we don't do Judet views as much as we used to do, but it's a good tool to start doing it if you are beginning. CT scans have overtaken the need for Judet views. And the key is to evaluate three things. How is the medial wall integrity? How is the ischium? And how are the ilium? I think these are the three things we should be looking into. And always, when you are looking or whenever you are in doubt, never hesitate to rule out infection by aspirating. Some people will do it for all cases, routine. But at least when the CRP and ESRs are out of range, I think a hip aspiration is warranted. And of course, 3D printing for complex cases, as shown in these two videos, will help you get a first-hand feel of how the bones are, what is the defect, and how would you want to plan the whole thing. Now, this is how the Judet will look. And I would just want you to focus on this red line and the orange line. If they are discontinuous, or if there is a break in these two lines, that means there is a pelvic discontinuity. I think these are very valuable, and these are basic anatomy that we should know, that if there is a break in the red line or the orange line, you mean you are probably dealing with a pelvic discontinuity. Now, there are a variety of classification. The most popular one is the Paporosky classification. And you'll find that there are a few slides that I've actually taken from Mr. Paporosky's or Dr. Paporosky's own presentation because they are so good. And I think what it does is it classifies on rims, walls, columns, migration, and lysis of teardrop. I think these are the basic fundamental things that we need to know whenever we are looking and planning for acetabular bone defect. And the AOS has come out with its own classification system in cavitary, segmental, combined, and pelvic discontinuity. Both of these are basically, or rather for that matter, any classification system is for us to clear our mind on what we are looking at. Now, this is the classification system. So 1, 2A, 2B, 2C, 3A, 3B, and this is the other side. So it's good for all of you to remember this because it helps clear the mind. In practical, you may not always need to put a number or a classification tag to this. But once you have a classification system, you start to look at X-rays and CT in a particular way and organize your thought, and that's very important. This is a Paprosky's original slide that I have taken, and it says, how do you assess this superior migration? The reference is superior obturator line and superior acetabular dome loss. If that's there, that means there is a superior migration of the hip center. If there is osteolysis of teardrop, it means that there is an inferomedial and medial bone loss. If there is ischial osteolysis, it means posterior inferior column loss. And finally, if you have a Kohler's line, it means that there is anterior superior column and medial wall loss. So it's very simple thing that Paprosky's, when he put his slide, that these are the lines, look at this, it will tell you what you are dealing with. And then he said, just if you have to look at whole thing, just look at and divide it in 3 types. Whether there is distortion of the hemispherical acetabulum, that's the simplest type 1. But if there is distortion but columns are intact, that means type 2. And you have a non-supportive column, that means it's type 3. And again in type 3, you have to know whether it is up and out or up and in. And I'll talk about that in my next slide. What does that mean? So you look here. So if the vector is going up towards the sciatic notch only, that means it is up and out. And if it is like a red bone, where this movement has occurred towards the medial wall, it is up and in. So again, going back to this, remember and look at the rims where there is distortion, look at the columns, and look at the direction of vector. So if you are systematic about it, how are the rims, how are the columns, and which way is the force vector, you will start thinking on how you will reconstruct the acetabulum. Okay. Now remember, when you're doing an intraoperative assessment, the defect may be worse than what you anticipate. So always over-prepare and then go with flow. First step is assess the rim and host bone support. And then you determine the needs for what type of implant you have to use. There are myriad of options available today, and we'll talk about a little more when we go. So it could be a jumbo cup, you can bone graft, you can put a structural allograft, you can do a cage reconstruction, you can have a cup cage construct, you can use augments, oblong cups are now more a historical view, or you can use triflange. So this is the armamentarium that you have. Remember, one of the basic principles is to have at least 3-point fixation. I think this is the favorite word of all orthopedics, 3-point fixation and column support. So this is the direction in which you have to have your at least 3-point fixation, and preferably anterior superior and posterior inferior has to be there. So if you get these purchases, you are almost sure that you will have a good 3-point fixation. Remember, that's the key. Our first point was stable fixation and then restoration of biomechanics and longevity. So the first step is getting fixation, and these points that I've marked are the key elements where your support will be maximum and your stability will be what you desire. Coming to the first one, capillary defect. These are the simplest one. It's a contained defect. My choice will be morcellized bone graft with impaction. You fill it in, pack it nicely. You use a cementless hemispherical cup with screws. If there's a large defect, you can use a jumbo cup if your rim support is intact. In segmental defect, the treatment options are porous metal augment, which is also called as TM augment, structural allograft, anti-protrusor cage, cup cage construct, and custom triflange components. And we saw the photos of each of this in my previous thing. So this is how you deal with this. These are the images of variety of things that is available to you. Now, when you have this type of this, so I'm talking about very common things. So first one we talked about was the contained defect, you bone graft it, then you put a hemispherical cup. But if there is a large superior medial bone loss, again, it could be only a medial bone loss without a rim loss or with a rim loss. So when you have without a rim loss, then you can again get away by packing the bone. But if you have a rim loss, you will have to use, or it's better to use either an augment or a jumbo cup. I would prefer an augment and a cup in the native acetabulum, because that is how the native biomechanics of hip is restored in the best possible fashion. When you have extensive rim and also column loss, so you look at this situation, if you look at this, the pelvis is completely separate, and you will need to think like a trauma surgeon also. You have to bridge that. Unless your column provides support, it's like a building. If you have your pillars are gone, you need to fix the columns. So either you can do it like a trauma surgeon, or you will need to have something spanning both the columns so that the force transmission occurs from ilium to the hip in proper fashion. So the decision-making flowchart is to assess bone defect, evaluate bone contact, and choose the reconstruction method. There are newer things that we all know in innovation. So tantalum augment, I think they have been sort of a game changer, because tantalum is one of those things that allow for good bone growth and should be exploited whenever possible. There is possibility of 3D printing the implants. Also remember that you have got something like dual mobility when you feel that you will have abductor mechanism deficiency or high risk of dislocation, where you can use it and put it to prevent dislocation. And also I often use biological enhancements like BMP. It has a limited role. I don't want to push for it, but when there is an extensive bone loss, I would use bone graft and BMP together to create a bed on which the implant will there, and that is my purpose for increasing the longevity of my construct. Remember that the common complications remain the same: migration, dislocation, loosening, and also the pelvic discontinuity requires two thinking hats, arthroplasty as well as a trauma surgeon. Your understanding of how columns are, what is the anatomy, is important. Let's look at this case example. Look at what's happening here. Think about for a few seconds. All of you think about, and then see what needs to be done. Okay. So we can clearly see that this is an force vector which is going inside, and probably the columns are also deficient. So what could have been done here? So you of course need to do a CT scan, look at what bone is available for you to reconstruct and what needs to be reconstructed. So here, when we opened, we found that the rim was good, and we put a cup and copious amount of bone graft, allograft plus autograft, filled in that area and held it with the screw. So you have to attempt to make it as primary as possible. So in this case, now we have a 3-year follow-up and the whole bone consolidated. So you'll see it's only a 2-month picture. Compared to this, see the amount of bone transformation that has happened here, and the bone has consolidated around the cup, and that's the key. You preserve as much as whole bone or create new bone wherever possible for the future. Again, this is example where it is going up as well as out. So it's going up inside this direction. The force vector is up. So you will find the defect is not only medially, but also superiorly. So you have to use something like this to bypass. This is a clear case of pelvic discontinuity. In this case, I use this to stabilize and bypass the whole thing. You look that the bone is very osteoporotic, and the purchase in this was quite flimsy. So it is needed to bypass and ensure that despite the column loss, we have been able to bridge it. This is a case of JRA, only a 19-year-old male weighing 17 kilos. Again, you will think that, oh, what to do? But in this, we had to use the smallest possible cup. I use a cemented one here, and a cage. These are the smallest available implants, and still they look so giant or huge to cover the whole pelvis. You will see. So you'll see all these cases, we have used different techniques. This is a case of a cemented cup, well done cemented cup 20 years back at a public hospital, and survived well. And this is how it came. And you'll see what we did. This is a T-Mars cup. Now, I think this has been a big game changer for us. Here, what we did was we filled up the defect. T-Mars is a tantalum cup, and you can put it in any direction and cement the liner or a dual mobility construct in it. For me now, this has become a primary stay of managing these cases. So in this case, I use this TMARS cup, and the acetabular thing has been cemented inside. You can see the acetabular liner being cemented inside. So in this case, it does look like in a proper orientation, proper inclination and version. But the beauty of the cup is that it can be placed in any version, any inclination, and then you can cement the liner or the cup in the desired inclination and orientation. And you can preserve as much bone stock as possible. Again, this patient is doing very well, almost 1.5 year follow-up and doing very well. This is another case. Now, just give it a moment to think what's happening here. Again, not everyone cups of tea to start with. You should do whether you should do 1 stage, 2 stage, what's the bone available. So we do CT, and this is what we did. This is thanks to my pelvic surgeon also. So when you need help, you can call your pelvic surgeon. It's Pradeep's case. You'll see that in single stage we put a lot of bone graft, screws, and there was a lot of discussion whether the cup is in or subluxated. We did a CT to see whether it's contained or not, and indeed it's contained. So you'll see in all these cases, we have used different options and not one thing fits all. This is just a flow chart of how you can approach different situation. You have to look at the hip center. You'll have to look for the potential for a biologic fixation, and you have to look at the columns. And depending on that, there is this algorithm. But for our mind, it's very clear. Look at rims, columns, and options available. How is the rim? How is the column? Is it up or medial? So if you don't have to have too big algorithm, these are the 3 questions you must answer. Whether the rim is good, whether the column is good, whether the migration is medial or it's gone superior. These 3 fundamental questions you must answer when you are looking at the X-rays and CTs. My preferred option is when you have a simple medial defect, you bone graft, you can use a BMP if you have access and cost is not an issue, and you use a porous cup. If you have superior defect and it's a segmental, I use a tantalum wedge and use an appropriately sized cup. I don't like to use a jumbo cup. And when there is a pelvic discontinuity, but the columns are good, there is potential of biological fixation, I'll use TMARS. And when there is a doubt, I'll use a dual mobility cemented inside TMARS. So this is my mind map. I don't follow too many big algorithms, but this has worked well for me. And you'll see in all of my previous 5 cases that I showed that we use different strategies. And the point of putting that was that yes, no one size fits all when you're talking about acetabular bone defect. Some common pearls and pitfalls: ensure that at least when you're going for uncemented things, there is 50% host bone contact when possible. Use screw fixation with multiple screw. Restore hip center and offset whenever possible. But I also don't shy away from having a high hip center when needed, and have a backup plan. So whenever you have, use the kitchen sink approach, have everything on with you so that you are comfortable. As I said, approach must be individualized, stable fixation, hip center restoration, bone stock management are the key things. The armamentarium has expanded because of BMP and TMARS, and now the era is shifting. We are also thinking in biology. So future revisions, you need to have good bone stock. So use every biological means at your option to ensure that the future of not only the longevity of the implant, but in case a revision is required, is taken care of. So just don't fill the void with metal, but with wisdom. So thank you, everyone. And thanks again, Professor Dave and Professor Khincha. I think Dr. Pachore is also here. He's the master of acetabular things. So we'll look forward to a very healthy discussion. And all the participants must use this opportunity to ask as many questions from the masters here.
Yeah. Thank you, Vaibhav. It was an excellent talk. I welcome Dr. Dhanashekhar Raja, my previous colleague for the scientific chair, and now he's a joint secretary for the Ishks. Very active member, very a great guy from Ganga. He's just joined, Vaibhav. Dr. Pachore sir is already there, but I think he's using a different link. So I hope he will come out with some questions or he will ask something, but let us see. Before that, Vaibhav, we just see some questions coming. Um, I just have two questions to ask you. BMP um, is quite known for the non-union fractures of the long bones. But use of that um, in this pelvic defect or a bone loss, I've just heard from for the first time from you. So uh, I think, is it only when you use the bone graft to use the BMP together?
Yes, sir. I mean, I have also, I mean, this is sort of something that I started doing it, and it's not a evidence-based thing. So I must clarify and give a disclaimer that it is what I do, and part of this teaching program is also to tell what you do and take feedback from people. So what I've found is that the ultimate, and I'm a great fan of BMP. I've worked in transgenic mice on this field, and I feel that the BMP has got great bone potential. And the key to acetabular bone defect is, as I said in my last slide, not just use metal. So when I put allograft specifically, so I use allograft, bone marrow aspiration, and BMP. So it's osteogenic, osteoinductive, and also scaffold. So you need all the three for the bone to form. When you have a sclerotic bone, the bone healing potential is less. So, so far, I've got good results. I don't know what really works, but I feel just like in non-union, where the BMP helps in bone formation, here where you have a medial bone loss and the patient is very osteoporotic and osteogenic potential is not that great, you can use allograft, bone marrow aspirate, and BMP to give
Yeah.
us stable medial support.
Yeah. Dr. Dhanashekhar, any comments from you?
Regarding BMP, you're asking, sir?
Yes.
BMP, I think in the initially it was very popular. I think now the popularity is coming down, but still in recalcitrant, non-unions and trauma side they use. Probably THR, probably we are not, hip replacement we are not used because we have in the primary case we have the head as a source. And revisions also with the newer fixation, we are able to get good osteointegration.
Yeah. Okay. Vaibhav,
Yes, sir.
role of CT angiography in, I think one of the case
Yeah, we
where
did it, sir. Yeah, we did it.
the socket has gone in. Can you just throw a light on that?
Yeah, sir. I think it's a great tool and it should be done wherever you feel that the migration is significant. And most of the time, because it has happened slowly, it pushes away all the vessels. But it is always good to document it. And also it gives an at least a thought process that if something goes wrong, that you had thought of it and you had planned for such a situation. Most of the time, the neurovascular bundle will be pushed away because of the slow migration. But it's not a bad idea. I did it for the last case. We did it for last case. We saw it, and then only we proceeded.
Dr. Pachore, sir, are you on the faculty link?
Can't see him here.
No, I think
What I'll do is, sir, I'll help him out. I will screen share his PPT instead.
My screen share is seeing now?
No, we can still
let us just, there are a couple of questions for you. Can you see on the question
Yes,
answer?
yeah. I'm just reading that question. The first question is from Dr. Pratik Dhabalia. He is asking, sir, please share tips on removing implant when the head breaks the medial wall and goes inside. Yeah, very interesting question. And it's very, very pertinent question. So most of the time when the head breaks the medial wall, so any revision situation, the first thing is patience. I think that's non-negotiable. All of us have to be very patient in such situations. The second is specific question when the head goes inside the medial wall, you have to be very gentle. Usually there is a good soft tissue, thick bone, a thick cover in front of the migrated head. The key is to use a hook and give. So that's why the question is you have to look at the X-ray and tell whether it has got, where is the vector going. If the vector is up in this direction, your force has to be applied in the same vector. Most of the time, people will put a hook and pull it horizontally, which is wrong. The way is to neutralize, just like any fracture reduction or any dislocation reduction, look at which is the direction or trajectory of your head. If it is up and above, you apply a force in that direction. You can even put a Steinman pin to apply force, but most of the time putting a hook around this will pull it. You need to have a good assistant who will give you the traction after you have sort of disengaged. And then once you have cleared the Kohler's line, then only you try to dislocate it by external rotation if you're using a posterior approach. I think these are the key elements. So to summarize, pull using a hook in the direction of your migration. Ask your assistant to give a traction. Ensure that the head has come out medial to the Kohler's line and it is sort of in the true acetabulum, and then use your regular maneuver to dislocate it. Patience is the key.
Couple of more questions, Vaibhav.
Yes, sir. Pulling it up. So, sir asked, it's sir only, Dr. Pachure has started the discussion by asking what are the indication of vascular study. As we discussed, I think it is important whenever there is a significant migration to do a vascular study. And for pubic screw, he has also asked about pubic screw. So as I said in my slide, you'll see that there has to be 3-point fixation, and they are quite important when, especially when your columns are not good, to have those in your hand. Does that answer that question? Or if anyone wants to add something to the pubic screws, Ashok, Prem sir, Dhanashekara?
I think pubic screw is important in case of pelvic discontinuity.
Correct.
Where you got to have a 3-column fixation. So pubic screw is important, and most of the cups don't allow you to put a pubic screw because the distance of the hole to the outer margin of the shell is quite far. So you need to specifically have cups which will allow you to put pubic screws, or in a tantalum recon cup, you need to build new holes matching the pubic area. So that's important. Any intra-pelvic protrusion of the cup, we need to have a vascular study. That's mandatory.
Yeah. So anything where, I mean, for me, it's more than 3 centimeter migration from Kohler's line, we'll get a study. And and you made a very important point that in tantalum cages like TMARs, you can actually drill in the direction what you want. So I think that's a great tool. And to get a 3-column fixation, it's a invaluable support system for us. Sir has also asked about the role of mock surgery. I think, yes, when you are, I mean, CT gives you an image, but doing a 3D printed model gives you a feel of this. You can put a trial cup, you can see the trajectory, and it certainly saves time. So I think, yes, mock surgery using 3D printed models are a good learning tool for all of us. Okay.
I think now 3D printing is available. They can get it in 1 week's time.
Yeah.
So they can plan the surgery beforehand with your 3D printed model. And then go ahead with the actual surgery. You can autoclave the ETO, the 3D printed model, and keep it on table also. So we can identify the direction during surgery also and use it. For making custom made cups also, this 3D printing is very helpful. And we can use those 3D printed models prior to the surgery and get your surgery worked up. Direction of the screws, the angle of the screws, everything can be worked up before surgery. It's a great tool now.
Yeah, indeed.
So Dr. Dhanashekara, how much time it usually they take to give you the 3D printing augment or the shell or something?
They say it is only 2 weeks, but sometimes if you are busy, you are not able to review the plan, it will take 3 weeks. 2 weeks is the minimum time, but usually we get it in 3 weeks' time.
Okay.
So I'd like to make a comment here. So I used to have a 3D printer at home. So I used to print all these 10-15 years back, but it's now not safe because it emits gases which are not good for you, we read. But in that, it takes 6 to 8 hours to print 3D printed models, which are plastic FDM printers using plastics. The advantage is that I actually used to write the numbers and then get it autoclaved. So you can do a mock surgery, write the screw size, draw the screw trajectory, and write it. It reduces your surgical time by almost 40%. Then we started the era of 3D printing the cups, which is called as SLM printers, which are the metal printers. They are expensive, and there are two big companies that make it, EOS and Rochette. And they typically started with 4 to 6 weeks. Now they've come down to 2 weeks. But personally, I believe that the era of 3D printing is sort of now going away for the metal printers. Because one, they are expensive, two, they take time, and third, their value is limited, because once you ream, once you open, once you debride, once you remove the things, then the structure changes, number one. And number two, with the availabilities of these tantalum cups, which can be dialed in any direction, and then the liner can be cemented, it's become really, I mean, there's unnecessary for us to now 3D print things. So I've moved from an era where I used to do one of the first few 3D printed cups in the country to a believer that it's probably no longer required. But yes, there are specific cases, unless you have got massive bone loss, tumors, and you feel that you will not be able to fill with a bone station. Those are very, very small number of cases where now 3D printed cups are justified in terms of time, money, and effort. But for others, I think the off-the-shelf implants are sort of good enough.
Dr. Dhanashekhar, we have any records on the long-term survival of these manufactured 3D implants which come from the manufacturers? Do you think we need to have the long-term series for the longevity and survival of those implants?
Yes, we have the long-term outcome. International companies, they have the data for the long-term outcome, more than 10 years data, up to 15 years data they have, but the outcome depends on the primary pathology. A lot of failures are due to infection, reinfection, for two-stage revisions and tumor surgeries. And osseointegration happens with these implants. They have shown good long-term data if it's done for pure bone loss situations. So results are good and encouraging, and I think it is going to continue interest for oncology and multiple revisions in hip surgery.
I think we take one more question, a couple of questions. And Ashok, are you getting ready?
Ready, sir. Yeah, ready. I think
Okay, I think we will take a couple of questions. We have few minutes, and then we'll switch over. Vaibhav, there are two more questions for you. One from Dr. Pachore.
Yeah. So sir has asked, what is the role of MRS Titan Comfort from Peter Brem? It's a beautiful tool, sir. I've at one stage when the TMARS was not available, it was where we can dial in the direction. So any version, anything that I talk about in TMARS could be done with this particular implant. It's called as MRS Titan. Okay? So actually, I saw it in action when I was in Germany with the professors who have designed it. So it's a brilliant tool, the Peter Brem. And if pre-TMARS era, pre our understanding of this era, I think this was a great tool because it allowed a lot of play with version and inclination and still ensured mechanics was restored. So MRS Titan Comfort, everyone should go through their PDF, through the surgical technique to understand the hip biomechanics better. They at their time, they really understood the hip biomechanics of revision as no one did. Any comments, sir, Pachore sir? Because you will have probably more experience of using Peter Brem for these situations.
Vaibhav, Pachore sir has joined from other link, so that's the reason he's asking questions. Yeah, he's not on this faculty link, so he's not been able to
answer it.
Yeah, correct.
Yeah, so the long story short, sir has started the discussion by asking about a brilliant product called as MRS Titan Comfort. I think all of us should read about that. It's a great product and for such situation. So it's from a company called as Peter Brem.
Yeah, Vaibhav, I can add some more points.
Yeah,
so
please.
The normal cage is not non-osteo-integrating, and you need to use a cemented system inside that. You need to cement a poly or a dual mobility with a normal Busch-Schneider cage. So this Peter Brem is the MRS Titan is one step ahead. We can use uncemented socket in that. In a young patient, we can fix uncemented socket, and there is provision to change the version by 10 to 15 degrees. That's the advantage of it. It has a more rigid fixation. It has a locking screw option to lock the screws into the ilium and ischium. So that's the advantage, but it's indicated mainly for type 2 Peprosky B type,
3B.
type 2 type of defect. Type 3 it may not work because it does not have that column support. So if any defect we can reconstruct with the additional augments and then put the Peterbram cup, because there is limited option to change the version and inclination, because the socket is angle is fixed, maybe 10 to 15 degrees, not more than that. Doesn't have the versatility of T-Mars cup, where you can actually cement in whatever direction you want. But it's a good
Yeah.
tool for us for bone loss.
But the advantage, as you said, Dhanashekhar, is
Yes.
uncemented, so better for a younger generation.
Yes, definitely.
Yeah, so again, as Dhanashekhar said, do we need now more of use of Peter Brem when we have got good augments with multi-locking screw?
No,
Now in this
I think
today's
now the
era,
usage come down. Yeah, it's come down. The usage is definitely come down.
Come
There's a very
down.
limited information now.
Yeah,
But
with
type
good
2
quality
defect-
augments and multi-locking screws in these augments and the better cups, I think.
Yes.
On them. Okay.
Yes.
So last question is, any literature on infection rate of 3D printed cups?
So that's
Dhanashekhar?
what I said. Many of the failures are in tumor surgeries and in revision for infections. The infection rate is higher, but it's same as the normal revisions, what we do with the metal augments and then cemented sockets. So the infection rate is similar, but 3D printing does not add to increased infection rate, but it's all depend on the primary cause of revision.
Yeah, I agree. There is no specific data on this, but intuitively, there should be no reason why they should have higher revision rate if the sterility procedures for packing these cups come from standard companies. In fact, if they also integrate better and their stability is better, the chances of infection is less. So intuitively, there's no data. Right. So I think that's the end of all the questions, and I think there's nice discussion. Any final words, Dr. Dipak Dave and President Khincha sir?
No, Vaibhav, I think it was a excellent discussion. Added to the flavor is presence of Dr. Dhanashekhar today.
Yeah, indeed.
Unfortunately,
As
Dr.
always.
Pacharak sir is not on the active link today. But on behalf of everyone, we thank Vaibhav for sparing time and coming on to this online teaching program. And on behalf of Krishna, Kiran, Dr. Prem, Dhanashekhar, Dr. Leo, and all of us, Dr. Pachore, we thank you for that. Dr. Dhanashekhar, can I just ask you to introduce Ashok Kumar, whom you know personally very well? I've just given a brief of him, but probably you can tell little more couple of words for him.
Sir, before that, can you see my screen, sir?
Yes, we can.
Yes, we can.
This is a big challenging for me. Now it's okay. So
Can you just move one slide, Ashok? Can you move one slide?
yes.
It's not moving.
Yes.
Can you see?
Okay.
Yeah.
Okay.
Right.
Yes, Dhanashekhar.
Dhanashekhar?
Please.
So
Okay.
it's a great pleasure in inviting Dr. Ashok Kumar. It's a good friend of mine. He's from the AJRI, Asian Institute of for
Orthopaedics.
Orthopedics. Yeah, they have all the spectrum. But he's a main robo man there. He does a lot of robotic assisted surgery, navigation surgery, and he has a dedicated interest in unicompartment knee replacements and the newer technology. He has been doing a lot of work on that. So he has also published on paper on unicompartment knee replacement and good data on that. So I welcome him to deliver the lecture on principles of unicompartment knee replacement.
Thanks, Dhanashekhar, and thanks, Vaibhav, and thanks all my seniors and professors. So this is going to be a short and very basics of the partial knee orthoplasty and current scenario. So the partial knee in 2025 is primarily indicated for patients with osteoarthritis or osteonecrosis limited to the single compartment of the knee and without significant ligament damage, stiffness, or inflammatory arthritis. The choice of UK is highly dependent on correct patient selection for optimal outcomes. So we're going to divide this teaching as a clinical, radiological, and intraoperative decision aid. So clinically, it should be a particular medial joint pain, medial joint bone and it should be only compartment 1 out. So the clinical, the patient points you exactly on the medial joint line, and clinically it should be a correctability deformity. So if you see the valgus stress, what you do preoperatively, that should be reproduced intraoperatively. So correctable deformity, this is the key step for doing any partial knee. The deformity should be corrected as you give anesthesia or pre-anesthesia as well also. So osteonecrosis, SONC, when the medical management is failed, then you should think of painful knee. The MRI should show no marrow edema, then you should proceed for UKR. So only very few indications, yes. So core indications, if you divide, joint stability, minimal deformity, good range of motion, non-inflammatory arthritis, and limited degeneration outside the compartment. So what are the evolving inclusion criteria now? Age and activity. Now accepted in younger age, less than 60 years, and active patients. When you come to obesity, the higher BMI patients can be considered if other criteria are met. So when you open a joint, you find a pristine joint with only middle compartment, you can proceed. Mild anterior knee pain and patellofemoral changes can be accepted, but not degeneration is accepted. So the true contraindications, still inflammatory arthritis, though some literature says can be done, but it's better not to do it. Ligament instability. Clinically, patient complaints of instability, we should not proceed. And multi-compartment should, more than one compartment should not proceed. And any stiffness and deformity can you see physically as well as clinically, do not do partial knee arthroplasty. So when you compare the traditional and the differential traditional indications, the Cousin and Scott is 1948 or 50, so very longest indications. So when you see this between the current, they all agree only in non-lateral joint tenderness, both the groups agree. Then non-inflammatory arthritis, no for both the groups, and range of motion minimum should be more than 90. So this is also no. So you see that remaining all what we said before has been slightly extended, which is within the limits. Once you finish the clinical indications, now the radiological. Without this Oxford series of X-rays, you should not proceed doing UKR. We need a scanogram to see any hip pathology as well as the knee pathology and deformity. And X-ray one leg standing is mandatory to document that it's only one compartment is bone on bone, not much of lateral opening. And lateral view and the valgus stress is a very important stress. It tells you the correctability of the joint as well as competence of the MCL, and there's no collapse on the mid lateral compartment. And skyline view is to see patellofemoral arthritis. If you're not doing arthroscopy, if you're not doing MRI, but these series of X-rays is mandatory to start your partial knee surgeries. Your X-ray operating room lobby should have all these X-rays before you start your partial knee. So 90% is decided pre-operatively. There's always 10% we tell our patients, we open it. The decision is on intraoperative finding. You see the medial compartment, AMOA confirmed. You can see the patellar's lateral facet should be normal, trochlea should be normal, and the meniscus should be good. And always look for the lateral compartment. The one thing in Oxford, we don't see the lateral compartment, but we like to see the lateral compartment and the lateral meniscus intactness. So the isolated AMOA with normal lateral compartment, shiny normal L. We consider 3 L's, lateral meniscus, lateral condyle of femur, and the lateral facet of the patella. So this is how it should look. And however, if you have the ACL, you can have a hook test, see the functional stability of the ACL intraoperatively by the surgeon as well. So in this case example, if you see the scanogram is very good, medial compartment OA, valgus is open, patellofemoral joint, no arthritis. However, when you open, we found to be there is a damage on the lateral side as well as on the patellofemoral. So this thing should not for UKR. This is to proceed for TKR. So the 10% decision is very important on table. So what are the basic concepts of UKR? There's a minimal soft tissue release as it's a minimal deformity. Do not correct to the, as a rule, to mechanical axis, undercorrect. Do not overstuff the compartment. And valgus is not the target. So conventional, not everybody can have the robot to do a UKR, but the conventional TKA, UKR challenges, technical challenges, it is a poor tibial alignment, eccentric loading, poor ligament balancing, overstuffings can cause lateral wear out, vertical sockets, and deep tibial resection can lead to revisions. So if you see, what are the variables that can influence UKR is accuracy, implant planning, soft tissue balancing, lower limb alignment, fixation, implant design, and patient selection. If you see 1 to 5, it can be challenging. 6, 7, it is very standardized. So if you see this, when you have conventional instruments, you cannot see the entire leg alignment. So you have to see the only short leg alignment. So there can be a lot of errors can happen. So that's the reason we need to have a whole leg scanogram and intraoperative assessment as well. So what happens to saw when you use a conventional saw blades? It can have a vertical socket. It can have a deep resection. So this is very challenging. So how to overcome these things? How to plan this tibial cut? So tibial conventional cut, first tibial cut is very mandatory in a conventional. So this is a one leg standing X-ray. You're planned for tibial cut. So, but however, the valgus trust tells you correctability based on this, not to take the 4 to 5 mm, since it's a correctable deformity, valgus very correcting it, try to remove the less amount of tibia on the medial side. So if you're planned for 4 mm cut on standing X-ray, the valgus stress shows laxity, then reduce the cut to 2 mm. So this is very key step. Now come for the conventional femoral cut. You see, anteromedial osteoarthritis, 99% is a distal femur wear only. It's an extension disease. It does not involve other part of the condyle of the femur. So it's an extension wear. So what are the key considerations? The distal femur cut, the blade can skive due to sclerotic bone. So how to overcome this? So desired depth is not achieved. So recut using the same slot. So this is very important point in UKR and distal femur. So normal on the posterior condyle is normal as always. If there is a posterior condyle involvement, there is an FFD. This is not for a UKR. So how to overcome this? The nowhere intact cartilage is present. So risk of undercut is there. So remove 1 to 2 mm of cartilage before placing the femoral cutting block so that you're not undersized or oversized. So this is a small video. You can see what happens is you need to play the femur in UKR. The medial compartment is worn out and only the distal side. You can see this only the distal wear. There is no wear elsewhere. All UKS have only distal wear. The posterior cartilage is normal. So when you conventional cutting guide of UKR, superior, inferior, or distalize. So this is very technically challenging. Only saw blades can, all the steps can skive. So you cannot move this in conventional fixed bearing uni. So how does the robotic helps? So robotic assisted UKR, the image based or non-image based systems, the planning has got the same algorithm. All surgeons should know the algorithm, use whichever robots you use. Only the external hardware is different. The saw or burr or arm or handle. So this is based on the system. So the robotic workflow overview, the data acquisition, some robots need CT, some request intraoperative mapping, Corey, Rosa, and Bellis, where the registration of anatomical landmarks is accurate planning and virtual planning, implant sizing, position, oriented cuts. So what we do, all the systems requires landmark acquisition, the femoral head. 2, it needs the femoral sizing points. The CT-based systems, though the surgeon doesn't do the sizing, but the sizing is done by the technical person, he has to know what are the landmarks to size the implant. The tide mark, most distal, posterior point. So the imageless robots use these registration points. You can see the tide mark point, you can see the most distal point, and the posterior point, and the center point. So based on the tide mark and the distal, all the robot systems take the size of the implant. It does not just give the implant by the CT. Even the CT technique has to be these points to be measured in real time. So in case of tibia, it needs malleolar, it needs the ankle center, it needs the knee center to be collected, then it needs the mechanical axis, most anterior point, low point, medial point, as well as the posterior point, and the intercolumnus. So these 5 landmarks in both femur and tibia are crucial for any robotic assisted technology. So now that was a diagrammatic. You can see how we do the in real-time live markings. You can see this. This is the tide mark. This is the medial on-out compartment of the knee on the medial side. Once you mark the tide mark, you mark the most distal point and the posterior point. So this gives the size of the implant of the femur. You see the ACL fibers. Some fibrillations are there. As a surgeon, you can have a hook to hook it. Check for the functional stability in real time. If the force is enough on your hook, you can completely and proceed for the UKR. So similarly, tibia, you can mark the intercondylar eminence, anterior, low point, most medial points. So these are very important landmarks for any robotic assisted surgeries. So what the robot does, restore the native joint, ligament balancing, minimal bone to be removed to preserve stock, femoral condyle to match, tibia to maintain the mechanical alignment and slope, and restore the parallelity of the patellar tracking. So UKR planning, you have all the landmarks. Next comes the planning. The plannings are the basic principles for all the robots, not specific to one robot. Every robot works on the same navigation planning principles. So once you have the CT scan, or you have the morphed bone technology, or you have the landmark technology, you need to take the implant base, centralized implant to the femoral component. 1, surface match to the femoral sagittal plane. 2, surface match to the femoral coronal plane. 3, get the rotation. So 3 screens has to be adjusted to the mapped bone or CT imaged bone. So this is the implant placement for the femur. Similarly, tibia, it needs a 4 screens. Again, you match to the anterior border as well as the native slope of the tibia. Similarly, not to overhang the implant, you can match to the medial tibial condyle and match the femur tibial rotation to the anteromedial surface in real time. So once you match the landmarks and the implants, all the robots gives you the balancing screen. Pre-op deformity of 7, half of the deformity to be corrected, not to overcorrect, not to too much undercorrect. So this is the graph. It shows the system here. It's a lax knee extension. You can just need to distalize the femur, get the balance. So fine tuning and balancing is what the robotic technology. You can fine tune and balance in real time. So gap balancing is virtually assess, adjust the resection and implant thickness to the symmetry, use intraoperative analytics and fine tune it. So the algorithm of the unicondylar is same as a total knee, lax knee, less tibia, tight knee, more tibia. The less tibia sense means it's 0.5 to 1 mm. The tight tibia is more tibia is not 2-3 mm, it's only 0.5 to 1 mm. If there is a mid-flexion tightness, try to move the femur up. So this helps you in balancing the UKR in technology-assisted surgeries. So how much of deformity you corrected? Half the deformity preoperatively can be corrected. If your pre-op varus is 0 to 5, try to be 5 or less than 5. 5 to 10 degrees of deformity, correct to 5 to 7. If it's more than 10, try to get to these 7 to 10. One good thing in robotic technology, you can assess the tracking of the implants in real time. So preservation of the structures, maintain the ACL, protect the patellofemoral cartilage, respect the collaterals and attached. So intraoperative fine tunings, confirm the planned and actual cuts, test the kinematics through the range of motion, final fixation. Micro adjustments can be done in slope as well as the rotations. So confirm the plan and alignment robotic data, check for the range of motion stability, then record all intraoperative metrics and documentation. So it's a short video. It's a less than a minute. You get the range of motion. This important is valgus stress. When you do conventionally, you have to do less judge, but where you can take the data, robot takes the data. You do the morphing of the entire femur. You adjust the components, surface match the components in real time, both femur and tibia. You can adjust the graphs. You can adjust the graphs, see the tracking. Then you can see where is the contact points. Everything can be done before executing. You can use arm, you can use a handle robotics. Execute the what you planned diseased bone to be removed in real time. Then put the trial components, check for the joint stability as well as range of motion across the things here. So there was a thing, implant selection algorithm for partial knee. When do you want to fix bearing or mobile bearing? Partial knee candidate, confirm the indications, ligament, isolated uni component disease, ACL, MCL intact, correctable deformity. Bone quality good, cementless bone possible. However, in India, we have cemented. Poor bone, cemented preferred. ACL integrity, intact and stable ligaments is mobile bearing is option. Doubtful, elderly, low active, fixed bearing is better. Compartment, medial, Oxford, Sigma, Journey, Zook, everything is available. Lateral specific designs, patellofemoral is a patellofemoral design. Surgical technique, Oxford, steep learning curve, fixed bearing, it is easily to be doable. So if you take over the registry, if you see robotic assisted UKR in Australian registry is a huge increase. So 50% of cases has been done robotically assisted in Australian registry has been seen. And whereas fixed bearing is the preferred choice of UKR in Australian registry in 2024 as well. There's a steep increase compared to the mobile bearing. So there's an 80% increase on use of fixed bearing. So key points, age, any age with isolated AMOA. Younger patient restore full function, high activity. Older patients, they have a rapid recovery. Consistent medial side pain should be there. Relatively normal ligaments. Focal AMOA. Intact ACL good function. Minimal correctable deformity. Patellofemoral component should be normal. No lateral facet or middle lateral trochlear wear should be there. It should be a non-inflammatory disease. So, Vaibhav, sir, anything clear?
Yes, very nice.
Yes, Ashok.
Yes.
Yeah,
So we have 5 more minutes, Vaibhav.
Yes, we have.
I would like to take a 5 minutes on the radiological assessment. We do X-rays, so how to see the X-rays? Because this is very important. So radiological assessment, the two distinct periods of time is intraoperative, immediate post-operative, later post-operative period. The monitoring is greatly affected by radiographer should be know what procedure we have done it. So the pre-op X-ray series is a prerequisite for post-op assessment. Without the pre-op X-ray, nobody can comment the post-op X-rays outcome. So same planning X-rays required and very important to see a full-length films, standard radiograph, standard AP and lateral. So we need a valgus stress X-ray to assess your post-op. So weight bearing, valgus stress, and the post-op X-ray. We always compare our post-op X-ray based on a preoperative valgus. It should open as it was preoperatively valgus stress. So if you look this post-op X-ray, tibia is overhanging, it's overstuffed, slope is more, again posterior overhang, the femoral PFJ joint impingement. So the tibial cut as we planned, it should be as much as lateral. There should be no varus cut. It should be proper cut to the tibial spine. So cortex should be as close to the tibial spine so that half of the tibial spine can be taken out, and look for the joint line restoration through the axis, and the component should be centralized. So that, and make sure lateral component joint line is also as well. So this is very important to create the joint line parallelity to see a good post-op X-ray. Similarly, the lateral compartment line, if you draw, it should go across the tibial poly of the medial side. And tibia femur centralization is very important. If you see the close, good, proper X-ray, you can see beautifully the polyethylene as well. So the poly, if you draw a line on the tibial spine and the femoral component border, you see it is not centralized. It is edge loading. Very important. So these are few things. Similarly, cementophytes. Cement has to be removed properly. It should not have impingement. And if you see the tibial coverage, it's good. Underhang, this is overhang. So this needs a proper lateralization of the implant. If you see the full weight bearing X-rays of the slope,
What happened to the presentation?
I think it's frozen.
Yeah.
The connection is lost.
Ashok, can you hear us?
Is he okay?
Okay, so we can start some discussions maybe. Is it right?
Yeah.
No, but without Ashok, what can you do?
Mhm. Shall I call him?
I think
I'll
so.
call him. You're calling him?
I'm
Yeah.
already. I'm calling.
Yeah, Dana is already calling, I think.
Okay.
yeah, I got it. Can you hear me now?
Yeah, sure, we can hear you, but we lost you in between.
The power I lost suddenly. Yes. Is okay? Hear me now? Can you hear me now?
Yes.
We can hear you. Yes.
Yeah, you can. Yeah. You can see the screen?
Yes.
Yes.
Yes. This connection was issue. Can you see the screen, Shaker?
Yes.
Yes.
Yeah. So, and the spec should be axis, and the PTS slope 5 to 7 degrees. There should be no subluxation. You can see the subluxation here. So again, the tibial coverage, there should be good coverage. There should be no undercover or no overcover. Yeah. Femoral tight mark, no not tight inside. And if you see the patellofemoral, it has to be well within the patellofemoral joint. So the take home, it shows overall HK limb alignment. Do not undercorrect the deformity or overcorrect the deformity. So special view is very important. In trial, you can look see to see how your tibial component is there. don't be shy. Use your intraop image to see how your coverage is there. So these are a few cases where we use CM to see how is our implant. That's why Oxford guys also use this intraop imaging. So cementation has to be well good cemented. It's because a single compartment. Make sure the good coverage of cement all around the implant, as well as medial, inferior, and even the sagittal plane as well. So the medial gap restored, lateral gap is retained, joint line parallel, femur centered, tibia is lateralized to the spine, tibial joint flush to the medial cortex, good tibial bone, zone of cementing, and femur is flush, and the femoral distal peg is fortified to the femoral component. And there's good cementation across the entire femur. Yeah. Thank you, sir.
Thank you, Ashok. I think excellent overview, especially the comparison of the X-rays and what are the salient points we should see in the pre and post-operative X-rays. There is one question for you with regarding ACL. Can you see the questions? Question box.
Yes, sir.
So there is one question for you on the ACL and uni. And further to that, I would like to add one more thing.
Please.
That would you ever consider arthroscopic patellar shaving and then do the uni? I think
no. We the moment when you do a uni, we don't do mini MIS approach. We do a mini standard approach. Ever the patella, denervate the patella. If any osteophytes are there, remove the osteophytes as well. There's no role of arthroscopy when you do uni. You can open it, you can do the denervation of the patella, remove the osteophyte as well in cases there.
Okay. And there's a question for you on ACL.
Ideally, if ACL is not there, you should not do it. But however, the lax ACL, I showed you the hook test. You can put a hook and hook it and see. If functionally is good, fixed bearing unis do very well with lax ACL as well. Yeah.
But no. What he's asking is, would you do ACL reconstruction and uni?
No. We have never done. We're not done it. Yes. But European surgeons do ACL reconstruction as well uni, but it's too much for the knee. That is. Usually, arthritic knee doesn't have instability.
So 10% of cases where you said that you need to assess on table, and you always keep the option of a full TKR ready on table?
Always consent is taken preoperatively, UKR but TKR. 90% or 10% intraoperative decision is very important.
Vaibhav, anything you want to add?
No. So I was saying that when the ACL is deficient, definitely the wear is shifted posteriorly. So the indication for doing uni is not there. You can do an HTO with an ACL reconstruction. That I do many times when there is an ACL and HTO. But with uni, I think it's pushing the envelope too far.
Correct.
And so I would not recommend doing that, because once your ACL is gone, and often when the ACL is gone, it's not non-traumatic ACL thing. That means that there is a disease process which is happening more than the biomechanical process. So the uni will not be the right option for these guys.
Suppose on MRI, Ashok, it shows mucoid degeneration. What would be your take on that?
No, as long as there is no instability, you can proceed with doing ACL, UKR.
Having heard quite a few people about UKR and the extended indications in today's day and age, and particularly people outside this country are having an extended indications. How many people who are doing UKR you think must have nodded to say, "Nahi, ye theek nahi bol raha hai"? How many of them will say, yes, whatever Ashok has said is not really right? That the indications for doing a UKR are still there in presence of early lateral compartment OA, in presence of early medial compartment patellofemoral OA, in presence of a lax ligament, and the extended indications for a UKR. This is just for the entire public, particularly the youngsters who are watching and who are participating, so that they don't go ahead with the wrong information, a wrong take-home message. I'm not trying to contradict you. You had a fantastic, simplistic presentation of a complicated subject, which can go on for half a day.
Yes, sir.
Right. So, can you just throw some light so that people can go home with some?
The message is, Since we do robotics now, UKR has become very popular. Robotics has not changed the basic indications for UKR. The robotics has not changed the indications of UKR. The very clinically first slide shows patient tells a finger point test. Ask where is the pain medial compartment. Only one finger point test. X-ray should be a bone on bone. And intraoperatively, I strongly believe, in spite of it should be a glossy, lateral meniscus has to be intact. Lateral meniscus has to be intact. Lateral compartment has to be pristine. Lateral facet of patella should be pristine. Trochlea should be pristine. So this is how the indications. Irrespective of the age, you open it. I have a 80-year man when I open pristine lateral compartment, only the medial compartment zone. ACL is not only synovial damage of ACL. ACL is not torn, no fibrillations. So these patients, when you open it, if you see there is a unique compartment, irrespective of age, sex, BMI, and deformity, not the gross deformities, you should not do for more than 15 degrees or less than 10 degrees. In India, we have always 10 is the number. We don't have 1 degree, 2 degree deformities. So,
Ashok, there are a couple of questions you can
yes,
read. Before that, while you read, I think I request Dana Shekhar to put some his comments and views.
So this Oxford group has come up with the extended indication compared to what Cosin and Scott has given traditional strict indication.
Yeah.
So according to the Oxford group, BMI is not a contraindication. Medial patellofemoral facet arthritis is not a contraindication. They say once you correct the alignment, it decompresses the medial patellofemoral joint and the pain disappears. So these are two things. And if it's an elderly patient, low demand patient, early lateral compartment arthritis, we still do because they are low demand. And the uni is a safer and simpler surgery compared to a TKR. So that is one more extended indication. So these are the few extended indications we do now.
But the Oxford, if indications we see, you can do for everybody. But we strictly in India, because of mobile bearing, no, but we strictly follow our own indications as every surgeon, or Khincha sir said, no, you open, you see, everything's intact, please proceed with this. Do not extend the indications, but as Oxford's young age, now we do for AMOA. I don't do complete damage, 40 years, 50 years, you have an active life. So elderly, very good, 70 plus, very faster recovery, less comorbid. They keep on, morbidity is very less. The activity is very good. The regain very faster. Uric acid, yes, you should not do. Sometimes crystal depositions are there. It's not to be advised to do in hyperuricemia.
And any BMI cutoff in
The
your
cutoff point of
practice?
BMI, 30. The BMI, some people have truncal obesity and the gait. If the BMI, high BMI patients walking without limp, straight gait, you can go ahead with this. If he's got a truncal obesity, waddling gait, it's not recommended.
Ashok, one more question on bilateral uni.
Yes, I do a lot of bilateral unis. Now the time is very shorter. People are not doing bilateral uni because robotic time takes longer time. I do a lot of bilateral unis. It's very quicker, faster, and it's very useful also as well. Benefit the patient as well.
I think Ashok, I think gout, I mean, uric acid is not a contraindication.
But not a contraindications, but something crystal orthopathy. If you tell not a contraindications, people tell multiple this thing, yeah. Not to do the crystal deposit.
Uric acid pathology, it is controlled with medication and intraoperatively you find the joint is okay, you can still go. The calcium pyrophosphate crystal disease is a contraindication.
Yeah. In fact, well-controlled inflammatory rheumatoid disease, even the Europeans started doing it. If DMR is well-controlled, they're doing it. But I don't think it's not recommended in this. Yes.
Yeah, so one of my rheumatologists asked me, why are you on that? Because now Tofazac and other drugs will control and they'll behave like this. I still didn't have heart to do it, but that's the thing the rheumatologists are asking this question.
So I have 2-3 patients follow up for 5 years now. Rheumatides. Incidentally, they turned up rheumatoid. It was pristine. You cannot find it out. So doubtful that the tissue came to be positive. Yeah.
So the problem with the uni is patients are thinking it's only half surgery, half replacement, and they say cost is same. And the longevity, if you can promise 20 years, then they'll accept. Otherwise, they're saying go do a TKR. That's a present situation now. So finding a suitable candidate who can understand this is a problem.
Yeah, and
But you
finding
think, Dhanashekhar, there are... Sorry.
and finding a suitable candidate who can understand that a day case or a single day admission of a UKR, and that UKR is as good as big an operation as a TKR is very, very difficult. I think you have done a minor surgical procedure.
Yes, sir.
But
In fact, there are people who project it by saying that it's a very minor procedure. We are not doing a replacement. We are only doing a gadi ka change. So
Yeah.
I know of people who say, sir, सिर्फ गादी का change कराना है. So I said, what does that mean? That means you can. So, we do get all sides of stories. Yeah.
But from what I gather by the fantastic simplistic presentation of Ashok, that Ashok is a safe surgeon. He wants to sleep at night. So he has really bound to his clinical indications, which we should appreciate. Although people around them must have been doing some extended indications and lost their sleep and lost their follow-up. So I'm sure Ashok, if he shows his follow-up, is much, very good follow-up results
Yes,
of successful end results rather than the extended results. So there's nothing wrong in that, to strictly follow your basic principles, your
Yes, sir.
basics, and have a good night's sleep and give the best to the patient. That's my take to the entire hearing audience.
Ashok,
Thank
we
you,
have
sir.
time for one more question. Last question you can take before we can
Yes, sir,
conclude.
please.
There is a question on BMI cutoff, so that is important.
BMI.
So what's your cutoff, Ashok?
BMI 30.
30, yeah. So generally everybody follows that.
So, Dhanashekhar, the thing is, there's something called truncal obesity and the overall BMI.
Yeah.
So I had interestingly a 38-year female with a classical AMOA. When I opened. So everything was pristine. So we said, at this age, you need this one. We tried. We did it. She's fine. Now it's been 2 years now. 2 years now. So, but the thing in our country,
You did a fixer or mobile?
Fixed bearing. Yeah.
So, Ashok, there are two quick questions.
Yes,
A role of, I think, poly exchange in revision, something.
No.
Yeah, I think probably this may be a dislocation in Oxford or something. That's what probably he wants to ask. And second is,
there's a role. In if the acute dislocation, there's a role. The chronic dislocations repeated, no role. We have to revise it. Suppose in Oxford mobile bearing, if there is some high stepping activity, hyperflexion or jumping, it can dislocate. Then poly can be changed. Yes.
you always increase the size?
It's not truly increase the size, but better to increase it. The Oxford
Sorry,
group
size means I'm talking about thickness. Sorry.
it's only 1 mm. There's nothing make difference. 1 mm, yes.
And the question is there on the some newer generation UKR?
Yes. Generation. There's nothing newer generation. There's
Only
only fixed bearing and mobile bearing.
Is ceramic coming in?
Hmm?
Is ceramic coming in?
No, sir. Right now, ceramics are there from
Oxynim.
the European. Yeah. Oxynim is there, and even the ceramics in Germany it's available there, but still not in the market. Yeah.
And the gold coating is also coming.
Yes, it's already there, gold coating, yes.
Okay.
Now the poly is improved, the poly quality is improved, techniques are improved, the technology is better now, so that longevity is expected to be more longer what was previously now.
Yeah. Okay. I think at this point we take opportunity. I think there is one more question coming. Okay. I think we take opportunity to thank Dr. Vaibhav and Dr. Ashok Kumar, Dr.
Recording
Dhanashekhar,
stopped.
Dr. Khincha and Dr. Pachore. On behalf of Krishna, Kiran, my colleague, and all other team members, we thank all of you, all the participants for making it very interactive. Both the lectures were superb, very nicely presented. Thank you very much. With last words from Dr. Khincha, I would just like to request the next month talk is going to be on 18th of October. We'll come out with 2 topics, 2 speakers, and send you all the details as soon as we are near the date. So it's going to be 18th of October, Saturday, same 7 to 8:30, hip and knee topics. Dhanashekhar, thank you. You joined this time and made it very interactive and good comments from you. Vaibhav and Ashok, thank you very much.
Sure.
Dr. Khincha, last word from you.
Thank Thanks, Vaibhav. Thanks, Ashok.
Yes,
Thanks, Dana.
thank you.
Make it every day, every other session. And I'm trying to
Sure,
get
sir.
the rest of the executive members also to be a part so that we have some interaction. And as I started in the beginning, that punctuality of Ishks has been a fantastic thing, and it is there. And punctuality is not only starting on time, but finishing on time.
Did you
And
finish
to
today,
you,
sir?
yeah, we finished exactly on time. And to you, two young surgeons who are doing a fantastic job, spread the message, get the youngsters to think in your lines, and take over so that in case we need an UKR or a TKR, then you can do a good job on us. That was the whole motto
Sure,
of
sir.
Ishks, to train guys. And I think you're trained better than all of us. So we should be able to come back to you soon. So thanks everybody for joining, and get more and more members into the Ishks group to join and get to the IJR. I hope that we get at least 1,500 members by the time we have the April conference. All
Thank
good.
you.
Good night. Good night, everybody.
Okay, good night. Good
Good
night.
night.
Thanks,
Good night.
Shekhar.
Thank you. Thank you. Thank you.
Thank you.
Bye, Ashok. Bye.
Thanks, Dana.
Bye.
Thank you. Thank you.
Okay, yeah.
Good night.